Well, good morning. We have a very important topic to discuss today, chronic pain and neuropathy, and no one better to discuss that than two of our leaders at Hoag's Pickup Family Neurosciences Institute, particularly the Chronic Pain and Neuropathy Program at the Kirche Clinic, our multi-specialty neurology clinic. Dr. Sean Zarduz is a neurologist, and neuro means nerve, I guess, Sean, as in neuropathy, meaning something wrong with nerves. So a neurologist is an expert in pain pathways, and also Sean did an extra amount of training, a whole year in fellowship, specifically in pain medicine. And with him is Matt Reed, a psychiatrist, and since our brain senses pain, disorders of the brain and amplification of pain in the brain are critical issues. Dr. Reed also did a pain fellowship, so he crosses both psychiatry and neurology. Very important topic, chronic pain. We Americans spend 3 times as much money of our healthcare dollars on various aspects of pain and neuropathy. Sean, let me start with you. What are the categories or causes of various types of pain? We all know that mechanical pain is probably the most common. I break my bone, I tear or strain a muscle, I twist my ankle. That's a mechanical cause of pain. But sometimes those can linger and become chronic. What besides mechanical causes, what other causes of pain are there?
There's various sorts of causes of chronic pain. One cause of chronic pain that's very common is neuropathic pain that involves the nerves of the body, whether they're the peripheral nerves or the nerves coming from the brain or the spinal cord. Other causes of pain are somatic pain or visceral pain. Visceral pain is due to the deeper internal organs, while somatic pain involves pain involving the muscles, the tendons, and the bones.
And of course, there are diseases or disorders that are related to categories such as infectious and inflammatory causes of pain, vascular causes of pain. If there's not enough blood supply to a nerve, that can cause pain. Toxic causes, various substances like alcohol, for instance, can cause chronic neuropathy. So not autoimmune causes like in multiple sclerosis and other immune disorders. So as a neurologist, knowing that panoply of causes, how do you approach making an initial assessment of a patient and then the diagnostic tools you use to ferret out which cause there is so that you can guide treatment?
Well, for every patient, it's different. It all depends on the history and examination of the patient. It's a thorough history and examination, looking at the source of the pain, the history of the pain, the severity of the pain, the triggers, and it relies on various factors, including the examination, additional testing, MRIs, CAT scans, X-rays. And based on that evaluation, we determine the source of the pain and the cause of the pain, and from that we come up with an individualized treatment plan to address that patient's pain.
Right, and I assume not all causes are easily learned, or there isn't, in some cases, a specific cause for the pain, and that's where the mind comes in. So Matt, I'm thinking of certain conditions that are still somewhat mysterious that clearly produce pain in the mind of the patient. Tell me about how the mind perceives pain and how you decide whether that's what's going on or not.
Sure. Any perception we have of pain is really contingent on an emotional component. It takes a toll. Anyone with a chronic pain condition or even an acute pain issue can probably empathize with the amount of dysfunction it causes in life, which can then cascade into depression and other anxiety disorders and things that further exacerbate the pain that's there. The brain gets used to how it experiences pain, and even once the original insult is gone, it's not that there isn't actually pain there. It is there, but it's perpetuated by these psychological factors at times. And really targeting them, you see great outcomes in the physical pain a person is experiencing.
That's great. I think we've just uncovered the importance of linking certain known causes of pain to combination comprehensive treatment, not just for the specific trigger, but also the effects in the brain and the role of the brain. So having the two of you team up on the leadership of our program is terrific. But Sean, so I want to get back to you, and obviously it depends on the cause, but give us an example of some of the ways that you can treat pain, depending on the cause, of course, but there are pharmaceutical approaches and there are minimally invasive approaches. So when is Advil enough, and when do you need to consider something else?
For the treatment of
And I hate to give a commercial to the pharmaceutical company. Whoever makes Advil, I wasn't paid for this.
For the treatment of chronic pain, we utilize a multidisciplinary and comprehensive approach. We often find that we're most successful in treating chronic pain when it comes to utilizing a multidisciplinary approach. And that approach relies on using medications, physical therapy, acupuncture, biofeedback, but also advanced procedures. So things like nerve blocks, epidurals, radiofrequency ablations, spinal cord and peripheral nerve stimulators.
Matt, let me turn to you. We see TV commercials all the time for various causes, various treatments of different types of pain, and there's usually disclaimers that go through all the things that are side effects that sound much scarier than the disease itself. But anyway, people think that there are magic bullets. Do you think that, for instance, in some cases, psychotropic drugs, antidepressants, or modulators of pain that change the way the nerves send signals to the brain? Gabapentin is one that is advertised. Do those have a role?
Definitely those have a role, medications do, and a lot of the psychotropic medications, which have previously just been thought of as helping for anxiety or depression, have been shown to really help with, in specifically, neuropathic pain. Think of tricyclic antidepressants. We use them in much smaller doses, but they can make a big difference for an individual with fibromyalgia and other conditions.
Again, not to say that those folks have a mental health disorder, it's just...
Yeah, totally separate from that.
Sean, I'm going to focus a little bit more on one specific type of pain that I know is a major component of all the different types of pain syndromes, and that's chronic back pain. We know that 4 out of 5 adults will suffer an episode of back pain at some point in their lives. And we also know that the outcome of treatment of back pain tends to be the same despite what's thrown at it, unless there's a very specifically identified cause, such as herniated disc pressing on a nerve, or severe stenosis of the spinal canal that presses on the nerves. So, but that's relative minority of individuals. All of us have back pain from time to time, and in some people, turns out to be chronic. At what point do you turn to Matt and say, you know, I've done a number of things in this patient, but how do we go from here?
So with back pain, it's a very common condition with which I treat. Firstly, it's identifying the source of the pain, whether it's a stenosis, a myofascial pain, facetogenic pain. Based off of that, we come up with treatment guidelines and treatment plans to address these patients' pain. These treatment modalities may range from physical therapy to injections to medications. But we often find that we're most successful with treating chronic back pain or chronic pain in general with utilizing a multidisciplinary approach. And oftentimes that also includes modalities such as pain psychology, pain coping, acupuncture, physical therapy, things of that nature.
So, Matt, you get one of these patients, they've been to our friends, the chiropractors, for 20 years, and obviously that approach isn't working because they have to keep going back. And so they come to Sean, and he can't find a specific cause. And how do you deal with those patients?
I really want to focus on the degree to which the pain has derailed what they want in life. I think ultimately to relieve suffering, you have to take into account how dramatic the changes in a person's life can be. And you couldn't help but develop depression, anxiety, things that further worsen a person's function. So gaining some hope that there's a way out of this, there's a way out, and often it will include another needle, another intervention, but in conjunction with some retraining, taming the nervous system makes a big difference.
One of the common things we see is primary care docs and other physicians, surgeons, after back surgery, for instance, will put a patient on opiates. And that can be a whole new bag of worms for those patients. We're trying to unlearn what we learned in the 90s, that we have to make sure patients suffer zero pain. And to that end, we made addicts out of a large number of people. How do you view the appropriate role of narcotics? Is there an appropriate role for narcotics in pain management? And then tell us about the unwanted aspects of narcotic use and how do you deal with those?
Sure. I think the frame point that I found most beneficial is it working? And if you're a person, living, breathing human, per opioid you take, you'll feel some temporary pain relief, but the overall pain condition often worsens over time. You see it time and again. For chronic conditions, often opioids further entrench dysfunction. And we've perhaps done wrong by people for a while. And reversing that and helping individuals come off of opioids, I see more often than not the pain condition is actually improved with no other new intervention other than a gradual decrease in those opioids. There's other safer opioids that perhaps don't cause as much of the worsening of the pain condition, like buprenorphine, which can definitely help, one, if there's developed an addiction component, but two, maintaining some level of analgesia with something that's more sustainable.
Yeah, one of the approaches we're trying at Hoag for postoperative pain is actually the use of anxiety relief with virtual reality programming. Patients wear goggles and are educated about their pain pathways, and it seems to be cutting the amount of postoperative opioids that are being used on our floors. So pretty interesting approach with some of the modern technology to engaging the brain and demodulating the brain sensation of pain. Even mechanical postoperative pain seems to have a lot of promise.
And we see decreased blood pressure, pain scores in the residential treatment program in addiction when using virtual reality as well.
Great. Well, thank you very much. I think we've covered the top of the topic. It's a deep, deep topic, but certainly for the purposes of general education around these issues and the fact that we have a comprehensive multidisciplinary approach to chronic pain and neuropathy at Hoag at the Kirchie Center is something we wanted to get across to our audience. So greatly appreciate both of you being here and have a great day.
Thank you.